Okay, Bismillah ar-Rahman ar-Rahim. Thanks a lot to the organizing committee. Patients post-tetralogy of Fallot surgical repair. What shall we tell our patients after the repair? After VSD closure, RVOT resection, annuloplasty, we must go through, with the patient through all these stations: early post-operative, late post-operative, who will follow the patient, imaging modalities, possible interventions that he may have, rehabilitation, what if he is going to have a non-cardiac surgery, what about pregnancy, and counseling of an athlete. We should start with the patient from early post-operative, or the patient guardians must know that he will get out of the operating room under ventilation until he regain all his respiratory and circulatory functions. Also, we will follow up his ECG. We may need temporary pacing or even permanent pacemaker if heart block persisted. Then, short-term follow-up we will follow up to be sure that there is no rebleeding, no pericardial effusion, no persistent elevation in right ventricular pressure, no right-sided heart failure, no sternal wound infection or atrial arrhythmias. Who will follow up the patient? Of course, his cardiac surgeon, his cardiologist or pediatric cardiologist. Later, he may need a cardiologist specialized in catheter-based interventions or electrophysiology. And later in his adult life, he may need a cardiologist that is specialized in adult congenital heart disease. Our diagnostic follow-up of the patient will include clinical assessment, 12-lead ECG, echocardiography, ambulatory ECG monitoring, cardiac MRI or CT in special cases. Our long-term follow-up of the patient, of course, will contain assessment of the pulmonary valve insufficiency and resulting RV dilatation, tricuspid regurgitation, or RV dysfunction. That's the most common problem we encounter in our patients. Residual RVOT obstruction, and the most important is the level of this obstruction, either infundibular or the level of pulmonary valve or peripheral pulmonary stenosis. If you are having a residual VSD and its size and hemodynamic load, aortic regurgitation, different types of arrhythmias and risk of sudden cardiac death, also our RV and LV function and risk of endocarditis. What are the imaging modalities that we will need and tell the patient that he may need later? Of course, our conventional echocardiography for assessment of RV function, for assessment of pulmonary degree of pulmonary regurgitation, and for sure now 4D echocardiography is almost comparable to cardiac MRI in assessment of RV volumes and function besides RV strain. Cardiac MRI is now of a crucial role in order to assess right ventricular volumes and function and degree of pulmonary regurgitation besides the shape of the RVOT, the pulmonary arteries, and infundibulum, the conduit. Also, it's important in assessment of the shunt fraction QP over QS in case we are having residual shunts. And late gadolinium enhancement helps us to assess amount of fibrosis, which is a very important, it shows us if the patient is at risk of sudden cardiac death and VTAC. We must be aware of the contraindications for cardiac MRI in order to tell our patient if he experienced syncope due to arrhythmia or symptoms of heart failure, pacemakers or ICD or CRT, which is not MRI compatible, other contraindications or severe renal impairment or claustrophobia. We may need a multi-slice CT. You must know what are the indications to do a multi-slice CT because of its high radiation dose. If you need to assess your coronaries, your MAPCAs, or your conduit calcification, so multi-slice CT is better as it has a high spatial resolution. Now, cardiac catheterization is saved to those patients who need intervention, or if any of your data by the non-invasive modalities is inconclusive. Now we'll go through some possible interventions that we actually met after tetralogy of Fallot surgical repair. First, I would like to mention the indications of intervention for patients with severe pulmonary regurgitation who are symptomatic, and if they are not symptomatic, if they are having severe RVOT obstruction or RV dysfunction or marked dilatation of the RV or symptomatic on exercise. Also VSD closure if it is of significant hemodynamic effect, or if the VSD is not significant but the patient is going again for surgery for pulmonary valve replacement. Here, if the patient is having a sustained VTAC, he may need to have electrophysiological ablation during or before going to the cath lab for pulmonary valve replacement or surgical pulmonary valve replacement. Also, if the patient is of high risk of sudden cardiac death with left ventricular RV dysfunction or non-sustained VTAC or symptomatic VTAC, or QRS duration more than 180 or extensive scarring by cardiac MRI, he may need electrophysiological evaluation or even ICD implantation. This is example of one of our patients. That's small VSD. That's not an indication for intervention. It's of very small volume load, but it's still an indication for prophylaxis against infective endocarditis. On the other side, this is a patient with a large VSD that was associated with significant tricuspid regurgitation. This patient has had his VSD closed by a duct occluder with marked improvement after. Another problem that we meet after tetralogy of Fallot surgical repair is peripheral pulmonary stenosis, especially in patients who had before an MBT shunt, like this patient who had markedly elevated right side pressure. And he had a successfully implanted covered stent. Another example that I would like to discuss with the surgeon, we met a left behind MBT shunt in this patient who had symptoms of left ventricular volume overload, and also she had other MAPCAS that was previously closed by a duct occluder, and we managed to close that MBT shunt. That is its closure. That was, sorry for the poor quality, that was one of the patients that had a pulmonary valve replacement by prosthesis, but he has significant pulmonary regurgitation. For this patient, it was difficult to assess the amount of pulmonary regurgitation and the actual diameter of this paravalvular leak. We used a sizing balloon in order to be sure of its size, and we managed successfully to close it with a vascular plug with marked improvement after. Another patient that we met that do not have only a VSD, he had also a Gervodi defect. This is flow from the left ventricle to the right atrium beside the VSD. It was technically difficult a little bit in order to close this defect, VSD and Gervodi defect together, but we managed lastly to close it with a multifunctional occluder, and that was the result, transthoracic echo of the patient after, with excellent result. But it's not always that beautiful and can be managed inside the cath lab. This patient had a quite large mid to apical muscular VSD that we decided to close and took the patient to the cath lab. She had a significantly dilated left ventricle, but we were faced with this multiple huge VSDs with no significant trims in order to position our device, and unfortunately that patient was sent back to surgery. Whether we can close these multiple defects or shall we do banding, I think we will ask the surgery after the presentation. And of course, we can now transcatheter pulmonary valve replacement is a great hope for patients now. We have quite large number of patients with severe pulmonary regurgitation that can be managed inside the cath lab. Now, regarding patients who are who will do a non-cardiac surgery if they are completely corrected with no significant lesions, so they are of a minor risk. If they still are having a residual defect, they are of intermediate risk. And if they are going to have a intermediate or high risk surgery, so it must be done inside a highly specialized center with a specialist in congenital heart disease available. As regarding athletes, if your patient is an athlete, so there is no restriction for exercise if he is asymptomatic with good hemodynamics. But if he is having arrhythmia with high risk of sudden cardiac death, or having biventricular dysfunction or aortopathy. So you must counsel him to do a low intensity activity and to avoid isometric exercise. And what is isometric exercise? It's exercises with muscle contraction, yet with no movement of the joint. So if your patient is of NIHA class 1 or 2, you can encourage him to do competitive sports. And if he is of NIHA class 3 or 4, competitive sports, of course, are forbidden. What about pregnancy? In completely corrected cases, the pregnant ladies can go through pregnancy well with good hemodynamic status. But if they are having significant residual lesions, they may suffer of arrhythmia and right-sided heart failure. Patients are unlikely to have, or the right side is unlikely to have an adverse long-term effect after pregnancy and labor. And according to WHO classification, pregnancy in a patient with totally corrected tetralogy of Fallot is class 2, which means that the patient can have her regular follow-ups every trimester, and she can follow up and have labor inside a local hospital. But if your patient is having a hemodynamically significant pulmonary regurgitation or VSD, she should follow up monthly or bi-monthly. You may need to give her diuretics. Also, you may need to have early delivery, but rarely we can need transcatheter valve implantation during pregnancy. As for the offspring, of course, there is a risk of growth restriction, and genetic counseling for the mother should be done. You should counsel your patient to maintain good dental hygiene, maintain good skin hygiene, and be mindful of infections, and consult his doctor, and do not to self-prescribe antibiotics, and show his card to any doctor before intervention. Of course, that's the worst thing you want to see. It's a vegetation on a pulmonary valve bioprosthesis in a patient after tetralogy surgical repair. It's class 1 indication to give prophylaxis against infective endocarditis in high-risk patients who are going to have a gingival or periapical intervention in his tooth. But it is class 2B indication if he is going to have intervention in other systems, and this is our prophylaxis antibiotics. Our take-home message is that patient follow-up counseling and intervening in the right time is crucial post-surgical repair of congenital heart diseases. Your decisions must be tailored to your every individual patient, and supply your patient with adequate knowledge to keep him involved in decision-making. Thank you. About the MBT shunt left, I would like to ask Dr. Ayman, what are the possibilities? Why shall we have an MBT shunt left after total surgical repair? Is it a sleep suture or missed by the surgeon?
So, okay, I'll go right into the presentation. I'll talk about the residual lesions and how can we manage at the cath lab. We'll focus on some of the common problems. We all know that pulmonary stenosis can come at many levels. So, and valve, supravalve, subvalve, up to the branches. And we have many degrees of severity and levels of obstruction. We'll talk about the native isolated pulmonary valve stenosis, and we know that we can dilate that with good results at the cath lab. The extreme form of the pulmonary valve stenosis is the atretic pulmonary valve, which comes with a variable degree of RV hypoplasia, and we were able to establish a program on intervening on this RVOT and perforating and dilating the atretic pulmonary valve. And this is our 10-year results. Okay. As we go up into the pulmonary tree, the interventions become more complicated and less predictable. So, on intervening on the peripheral pulmonary branches, you cannot really predict how this patient will respond. We hope they respond well. This is an example of the peripheral pulmonary plasty. Sometimes we need to put a stent if the area allows the length of the stent. But we are now talking about residual lesions. So after we perforated the valve, we noticed in some cases the development of a subpulmonary membrane. And this seemed to occur in some cases. So we've recorded 5 cases out of more than 100 cases that we've done. And we have tried ballooning this lesion, but it doesn't respond. It's actually a fibromuscular membrane similar to the subaortic membrane. The patients with the pulmonary atresia that we have intervened on in the neonatal period, we were able to go back in due time and put a valve because of the significant regurg and dilatation of the RVOT that they get. So this is solved by the valve. We had a total of 5 cases. We put in Sapien, a Melody with pre-stenting, in this case with straightforward tubular main pulmonary artery. This case had a dilated MPA and a short annulus to bifurcation, so we used an Edwards Sapien valve. In our series, we used 3 cases of Sapien and 2 cases of Melody. Shifting to Tetralogy of Fallot, which is the core of this session, we have place in the cath lab for some palliation prior to surgery in the critically ill neonate. So we can stent the ductus and we can stent the right ventricular outflow tract. But the surgeon has to go in and repair the lesion. Again, the lesions are not so simple as the straightforward tetralogy that we wish for. So he might need to do transannular patches, patching the pulmonary branches, or even put in a conduit. And we can get many types of surgical approaches. And from our side, we get also many kinds of post-operative residual lesions. So we are all aware of the residual regurg that happens after the transannular patch, the dilated RVOT, and eventually this patient needs a valve. So with this dilated RVOT, we had to put in the P valve. This patient with transannular patch with mixed stenosis and regurg was managed by a Sapien valve without stenting. This patient who was tetralogy with absent pulmonary valve had significant calcifications, and he had to be pre-stented, and then we put in an Edwards valve. Again, a conduit calcification might be so severe and so tricky. These procedures are typically not quite easy, so they require pre-stenting and then a valve. We lots of times see associated lesions like most commonly origin LPA stenosis. Sometimes this is not significant, but sometimes it is, like this case is moderate, and we need to stent the LPA as well as put in a valve. In this case, it was a pulmonary valve, a P valve. This case also did a transannular patch and then did a biprosthetic valve and presented with biprosthesis dysfunction with severe stenosis. And this case was actually planned for a valve, but he responded to just balloon dilatation alone. So currently he's following up on that. In this case, the child had dilated RV, dilated RVOT that reached the significance of doing an intervention. However, the child was small, and we had to go through an apical approach by hybrid procedure and put in a P-valve. So it's all about selecting the case. Who will I intervene on? Do I need intervention, and when do I intervene? Do we wait until symptoms arise? I don't think so, because once symptoms develop, maybe it's a bit too late. Do we go by indexed RV volume? We have guidelines, but these guidelines are being challenged now when we aim for a lower volumes to prevent dilatation and irreversible changes that happen to the RV. We sometimes go by the MPA size and RVOT size. We don't want these kids to develop aneurysmal RVOTs that become so difficult to treat later on. But it's always a balance between the size of the patient and the size of the RVOT. And the most challenging cases, those with mixed dysfunction, with funny RVOTs, and these are difficult to cross, difficult to manage. But we always have to study the cases, study the morphology. Which case do we need to intervene on? Which valve do we need? Do we need pre-stenting or not? Do we need to address associated lesions? And how will we approach the case? In all our series, we did like a total of 13 cases of Fallot. Only one was hybrid, and the rest were transfemoral. We didn't do any jugulars because the patients were too small for a jugular approach. So with the expanding and developing devices, we eventually might be able to adapt all kinds of morphologies. But again, we need to know that the surgeon is our friend, and we might need to refer the case with unsuitable anatomy for intervention. And thank you so much. I guess I didn't exceed the time.